Welcome everybody to this talk. My name is Mike Pelkey. I'm a consultant physician here in London, and this talk is about the basics of mechanical ventilation. And we're going to start very simple and try to get a little bit more complicated during the talk. I hope I can keep your attention for the entire time. I do have some disclosures which are listed here. So what I'm going to try to address in this talk is, number one, what is respiratory failure? And I have done a separate longer talk on this for people who want to get into the detail. Second, why does it occur? How do we treat it? And how does NIV actually work? So very simply, the function of the lung is to get the good gas in and the bad gas out. The good gas, of course, is oxygen, and carbon dioxide is the bad gas. And normally the system is well balanced, and the capacity of the respiratory muscle pump, which is the diaphragm and the other muscles, is roughly balanced or exceeds the load on the system. And indeed, if you think about it, it has to be so, because otherwise, if there wasn't an excess capacity, then you would never be able to increase demand, for example, to exercise. And we know that various things can change that balance, and I've just got a couple of examples here. The man on the left has motor neurone disease. The lady on the right has gross scoliosis, which makes the system harder to inflate. I think the other point I would make is that non-invasive ventilation has been on a bit of a journey. So the very first positive pressure ventilators were in the 1900s, and even before that, people described methods of trying to resuscitate people from drowning using, bags made from animal bladders and so forth. I think it's probably fair to say that modern ventilation really began during the polio epidemics of the 1950s, when the iron lung was created, and really began to become mainstream in the 1980s. When then and in the 1990s, we started to use non-invasive ventilation, particularly for people with neuromuscular disorders. And we began to see that there was improved outcomes in Duchenne muscular dystrophy and other conditions. So the point I would make is that this is still quite a recent phenomenon. So some of the senior colleagues in your hospitals may, if they've diversified into other specialties, may not be that familiar with non-invasive ventilation. So it's important to spread the message. And in particular, one of the things I often find is that colleagues who are not in the field confuse non-invasive ventilation, which is an active way of supporting the patient, with CPAP, which is simply a way of holding the upper airway open, or in some cases changing lung volume. The essential way that non-invasive ventilation works, just to keep it very simple, is that it assists the respiratory muscles. So there's not much you can do very often to reduce the load on the system. Sometimes there is, you can give somebody with acute COPD, let's say bronchodilators, but generally what the patient has disease-wise is what they've got. So the only way you can really help is by giving the non-invasive, giving the respiratory muscles a helping hand. And so in that sense, you can think of this like those moving walkways you see in airports. You still walk on them, but you go faster because the walkway is moving. Let me just talk you through this in physiological terms. This is a study that we did in healthy volunteers, and we've used two different levels of pressure support, 6 and 12 centimeters of water. And we've got spontaneous breathing here on the left-hand side. So let's look at the normal breathing first of all, because that will tell us how we breathe. So what you've got here, just where I'm moving my cursor, is pressure measured from a balloon catheter placed in the stomach. And here you've got pressure from a balloon catheter placed in the esophagus, which of course is a reflection of pleural pressure. And the arithmetic difference between these two pressures is the transdiaphragmatic pressure, which is shown here. So when humans breathe spontaneously, they create a negative pressure in the thorax. Once the pressure is subatmospheric, then air flows into the thorax from outside, and you can see the airflow here. They then breathe out. That's usually a passive process, although not always when people are exercising. So here we have the expiratory flow, and the inspiratory flow, of course, is associated with the activity of the breathing muscles, and here you see the diaphragm EMG. Now, when we give a small amount of pressure support, and those of you in the game will know that 6 centimeters of water is not a very big amount of pressure support, the first thing that we start to see is a reduction in the esophageal pressure, because of course we're pushing pressure in. But because the ventilator is assisting the breathing muscles, despite the breathing muscles producing less work themselves, you can see here the diaphragm EMG has also gone down. Actually, the amount of flow has gone up, because the point is that the ventilator is assisting the patient to breathe. And if you go to a higher level of pressure support, here we've got 12 centimeters of water. All of those changes I've just shown you are more extreme. So we've got a further reduction in the diaphragm EMG, a further reduction in transdiaphragmatic pressure, and even bigger flows. So that's what NIV does. Now, there are multiple ways that you can give this, and I've just got a few pictures here. This man is doing mouthpiece ventilation. Obviously, the classic way is to use some form of face mask, and there's a selection of face masks there. And again, just for completeness, you can see an iron lung. People amazingly would travel on aircraft with these devices that weighed over 300 kg, obviously very seldom used now. Now, we wanted to ask the question of how does NIV work in the long term? I've shown you how it works in the short term, but what about the long term? This is a study that we did in my laboratory 20 years ago now, and we took some patients with neuromuscular weakness, and we took some patients who had curvature of the spine. So these are, in the broadest sense, patients with chest wall disease. And we studied them on day 0, day 5, and month 3. And of course, we were able to confirm their usage of non-invasive ventilation by download from a device. And we tested various theories as to how respiratory failure occurred in order to ask the question, how does NIV work? So the first was on strength, and you can see here that the strength of all of these parameters in inspiratory terms and expiratory terms improved, but the twitch times diaphragmatic pressure did not. So we did not think that fatigue was causing this, and we also did not see any change in the stiffness of the chest wall, which is shown in this table here. What we did see, however, was slightly more so in the neuromuscular patients, but in both groups, an improvement in the sensitivity of the patient to carbon dioxide. So what we learned from this is that by providing non-invasive ventilation, what we were really doing was resetting the control system in the brain stem so that the hypercapnic ventilatory response recovered. In chronic obstructive pulmonary disease, we did a similar design study, and we saw very broadly similar results. So again, what you're doing when you give non-invasive ventilation over a long period in all of the main disease categories is to reset the brainstem control of breathing. Following on from that, and this is a logical thought, we now know that more is more. So Michael Dreyer and his colleagues did this first study, and subsequent bigger studies followed, but they asked the question, how low should we be driving the CO2? In other words, are we better giving a very aggressive program with the view of getting the CO2 completely down, or should we just give a little bit of ventilation? And the answer quite clearly is that if you're randomized to high pressure, and this is a complicated design, but these are the two groups at baseline, and half of them did high pressure first, followed by low pressure, and the other half did low pressure, followed by high pressure. You can see that the CO2 levels measured in millimeters of mercury here are higher if you're in the low intensity period. And there, as I say, there have been other bigger studies, but I showed this one because this is the first. So we know that you should get the CO2 down as low as you feasibly can, because that will give you the better result. Of course, when you're doing ventilation, there are some other things you might need, and I'm just going to touch on them briefly, but I know that they will be the topic of other podcasts. One thing that people with respiratory failure get is difficulty getting rid of their secretions, and I've shown you that non-invasive ventilation can be thought of as a form of assist for the inspiratory muscles, and you can do the same thing for the expiratory muscles. So what this type of device does is give a positive pressure to fully inflate the lung, and then apply a negative pressure to suck out material from the airway. And these are some physiologic data, but you can see that when the machine is used, you get greater expiratory flows. I think the other thing that is not directly related to non-invasive ventilation, but what are the options if non-invasive ventilation fails? And that will depend a little bit on, of course, what condition the patient has, but also what their wishes are, what the healthcare resources are like in the country in which you live. But there are complex decisions around whether you should be using palliative care, whether the patient may even wish to come off the ventilator, or conversely, whether you're going to move to long-term tracheostomy ventilation. And tracheostomy ventilation, again, is, I am sure, the subject of a further talk. But what is important to remember, bearing in mind that you need to offer the patient their advice, is that the burden changes a lot depending on how much non-invasive ventilation you're using. So in the sort of entry level, if you like, where you might use non-invasive ventilation at night only, don't forget you're doing this in order to reset the brainstem's chemosensitivity. They might typically use it 6 hours a night. They might go to clinic, in this country anyway, once a year. The ventilator will need to be checked once a year that it's still working. But this is overall, this is not a big intervention. If you're more ventilator dependent, and in the UK we tend to define that as more than 14 hours, you're going to need 2 ventilators. You may well need to do sleep studies to check that the prescription of the ventilator is optimal. And for the patient, when they want to go out, they've got to make sure they've got either a power supply or enough battery power to keep them going to their intended destination. When the patient develops expiratory muscle weakness, they will need to have some form of physiotherapy with or without a mechanical insufflation-exsufflation device. They may use alternative techniques like breath stacking or mouthpiece ventilation to achieve lung inflation to allow them to have airway clearance. And certainly in our service, those people will then require visits from our outreach team who will visit them in their own home. If they become totally tracheostomy ventilated at home, they will need 24-hour carer cover for somebody who's sufficiently skilled to change a tracheostomy if it falls out and becomes blocked. That, of course, then makes travel extremely difficult, although not of course impossible, and comes at a cost of a loss of privacy because you have to have somebody with you the whole time. So when we think about non-invasive ventilation, it's important to understand that this is a range of options, a range of burdens, and a range of costs, if you like, for the healthcare system to deliver. It's not a simple one-size-fits-all. So just to summarise, non-invasive ventilation works essentially to boost the capacity of the pump rather than reduce the load, and that's an important concept. And it works short-term by doing that, but over time it works by allowing carbon dioxide sensitivity to be regained. So I'm going to stop there. I hope this has been useful for you.